Hi, everybody. My name is Hannah Meixner, and I'm a paramedic from Grand Rapids, Michigan. And I'm here to talk to you today a bit about lower leg immobilization secondary to trauma. The reason I'm bringing this up today is because I've personally witnessed a pretty significant training deficit when it comes to splinting in the field. And not only is this one of the cooler things that I feel an EMT basic can do in their scope of practice, but it significantly improves patient care and instills a lot of confidence in the provider that I really don't think that we are providing currently. So whether this is a brand new skill for you or you're just sharpening those tools in your toolbox, by the end of this presentation, I'd like you to recognize when we need to splint and feel confident and comfortable applying a splint that properly immobilizes injuries and is comfortable for the patient. That is the whole point. So this is my point. So all of these are bad examples of splints. I was asked to proctor a EMT psychomotor exam not too long ago, and these are all the splints that they presented me with during a scenario. So do all of these look comfortable? No, not really. Put yourself in their shoes. They're splints, I guess. And are you going to be comfortable if your leg is broken? And secondarily, are they fully immobilized? Well, you might think so. Maybe that top one looks immobile, but by the end of this presentation, you'll realize, no, that is not proper immobilization, and I would love to show you how we can do it better. Today, we are focusing on the lower leg, the tibia and fibula. The upper leg, the femur, has its own set of rules that will definitely cover during a later presentation. So there's a lot of things going on with the lower leg. I'd like to point out too that the ankle, the malleolus, is not its own bone. It's just the terminus, the end of the tibia and fibula. Check that out. All right, let's get down to business. I want to give a shout out to my little brother Connor. So this photo was taken about 15 years ago. He was roller skating, landed weird, and oof, look at that edema, that swelling to his lower leg. Can I definitively tell if it's broken? No, I don't have X-ray vision. They don't pay me enough for that. But unless a bone is physically sticking out of the skin, you will not be able to tell. Hints that something can be broken is that it's unstable, right? Obviously, if he has zigzag legs, probably broken. But if there's just a slight give to the bone, you hear that crepitus and feel it, that crunchy feeling. Ooh, gross, right? Might be broken. Bruising doesn't appear till later. Pain is relative. Bleeding, if it's sticking out, of course, that's a compound fracture, but if it's still inside, may or not be bleeding. Bleeding internally makes bruising, right? Most dangerously, we have our vascular compromise. That means distally to our injury, we are not getting circulation. Distally means further away from the body. So that means our hand doesn't have a heartbeat or foot, right? It's getting cold, it could be numb, could be losing sensation. Does it matter, though, if it's broken or sprained or strained or dislocated? No, it doesn't matter. When in doubt, we will splint it out. And was it broken? 100%. That is totally a broken leg. You poor little buddy here. You can tell he's in a lot of pain. What are we going to do to manage this pain? We are going to give RICE therapy. We will rest, ice, compress, elevate. So most of us as adults have at least rolled our ankle at least once in our lives and have probably heard this. The reason we RICE is to reduce swelling. Swelling isn't all bad. Swelling is our body's reaction to the injury. It is essentially making that body part more rigid, creating its own cast, protecting the injury. But unfortunately, that swelling increases pain. If we reduce that swelling, it is very imperative that we create our own cast or our own splint around the injury and stay off of it, or else that injury is susceptible to even more harm. So over-the-counter medications that we can take for pain management include ibuprofen, which reduces swelling. Swelling is reduced, pain is reduced, and acetaminophen. So acetaminophen just tricks the brain, say, hey, what pain, right? Cool thing is you can take both at the same time because ibuprofen is metabolized in the kidneys and acetaminophen is metabolized in the liver. There's no danger. So first and foremost, we are going to treat major bleeding. That is major bleeding. He's in the corner. If you could see me, I saluted him. But if somebody is significantly bleeding, we are not going to focus on any broken bones. We are going to focus on our life threats first. We can control this bleeding with direct pressure or a tourniquet, of course. Next, we are ensuring PMS, pulse, motor, and sensation. Do they have a pulse distal to the wound? You could check their radial pulse there or their pedal pulse in their foot. I'll show you a diagram of that in a moment. Can they give you jazz hands, wiggle their fingers, wiggle their toes? Sensation, can they feel you? I ask, what finger am I touching? Note, don't say, which toe am I touching? Because nobody knows where their ring toe is. I say, am I touching the top or bottom of your foot? So speaking of feet, this is where we find our pedal pulse. This person is palpating their dorsalis pedis. This vessel comes down the ventral, the top side of your foot, and bifurcates right by your second toe. You have to have a pretty light touch to feel this one, and if they have a low blood pressure, it's kind of hard to palpate. This being said, you should have a pen or a Sharpie on you. I would put an X or circle around where you found it originally so you, your partner, or the hospital can find it later. Next, we're gathering our supplies. These are all the things that we have on the ambulance. Notice those orange rectangle things. Those are our rigid board splints. It's just a piece of wood with padding wrapped in plastic. That's what I'm going to be using, but you can use anything that is long and rigid enough. You can use broom handles, you can use sticks, you can use tent poles, you can use trekking poles. Can you tell I go outside a lot? But if you improvise, ensure that you pad them enough so they are comfortable. So fortunately, this patient is presenting with a straight leg, but that's not the case all the time. Sometimes it looks like the poor guy has three different knees, right? So when that happens, we are going to assess PMS, and if they have pulse, motor, and sensation, we will splint in the position found. That will be another presentation with some more advanced splints. But if they do not have PMS, we will gently pull traction to try and straighten that angulation. We have one chance to realign this. If there's resistance or we're faced with significant pain, we'll stop immediately, splint into position found, and transport. So like I said, fortunately, this is a straight leg. I'm going to use these triangle bandages. I prefer them over ACE wrap because here I can go under the knee in the knee pit or the popliteal fossa or behind the ankle, right where the Achilles is, to shimmy these down and up and in their correct spots. Because with an ACE wrap, you will be holding the leg, continuing to manipulate it, causing further pain. Next, we are immobilizing the ankle. We do this because for full, complete immobilization, we must make sure that the ankle and the knee, the joints distal and proximal to the injury, are not going to move. So I molded the SAM splint. It's essentially really rigid tinfoil wrapped in foam around his uninjured foot, and then put it on his injured foot. We do this so, of course, again, we're minimizing movement of the injury. Next, imperatively, we are padding. So you can use whatever you want. I used a towel here in a taco form, not the burrito form. We don't want to wrap around, but you could also use blankets. You can use pillows on either side, but this is really what's adding that additional support and comfort for a patient. We add our rigid components here, be it our board splints or our sticks or whatever, wrapped in blankets. So this splint is really coming together now. I am going to straddle the patient's leg and squeeze these boards together with my knees, tying all the way down. I like to say pros tie bows. The reason we tie bows is because keyword, they're adjustable, right? Note, I also tie them on the side of the board because if you have open and exposed visualized this injury, you don't want to tie these knots directly on their skin. You don't want to pinch them or pinch their leg hair. That's an ouch. Here's a quick demo on why we do two ties above the knee instead of one. Look at that right photo. That one tie is acting as a fulcrum. That knee is not immobilized. He can totally move, right? That's why we need two. Okay, so here is our super secret pro move. What you're going to do to ensure maximum stability, you are going to squeeze together the end of the splints with your knees and tie a pretty little bow. That's the other reason we do bows, because they're pretty, right? Every time I've ever done this to a real patient, they say, wow, that's significantly more stable or more comfortable or whoa, that's really in there. It's kind of cool. We're nearly done now. Remember rice? So now we're elevating our legs. I threw an ice pack on there. And notice I took ace wraps at this point and buddy splinted. This means I connected both of their legs together. This just makes transport a lot easier. This is our last step. We will recheck PMS, pulse motor sensation. If they do not have PMS, what do you think happened? Usually means your splint is too tight. So that's why we did bows. We are going to loosen them just slightly. And all said and done, PMS is in check and your splint looks like that. You can now high five your partner because dang, that's a good looking splint. So now we're circling back to the beginning, right? From everything we learned in this presentation, I hope you now see why each one of these splints would be insufficient. Here's the catch though. Your splint does not have to look like mine to be successful. If it works, if it immobilizes what it needs to immobilize and is providing the patient comfort, it's not stupid. I'd really like to see what you all come up with. Well, I hope you learned something new today, or at least sharpen your skills a little bit. If you have any questions, comments, or poetry about splinting, I'm always on the hunt for the latest and greatest in pre-hospital care. I love new gadgets. It's a great example. Definitely the latest, maybe not the greatest. Here's a photo of me in an inflatable sea collar. Here's all my information. I would love to hear from you. Please stay safe out there. Bye.